Janeway lesions in MRSA mitral valve, acute bacterial endocarditis. Janeway lesions are rare dermatological manifestations described as irregular, non-tender erythematous macules or papules in the palms and soles of patients. Although there is contention about the pathophysiology of these lesions, they are thought to be vascular phenomena secondary to septic microemboli. They are part of Duke's minor criteria for the diagnosis of infective endocarditis, and their expedited recognition leads to decreased morbidity and mortality for infective endocarditis. We're going to be presenting the case of a 38-year-old man with history of AIDS and late-latent syphilis who presented with severe acute back pain, fever, and Janeway lesions following the formation of a result skin abscess 6 weeks prior. The first a cutaneous abscess developed after the patient raised his chest, and the biggest one was of 5 centimeters. Another lesion developed on his thigh with similar appearance, and these two lesions are believed to be the site of inoculation for MRSA. 6 weeks after, the patient presented with the fever and the worsening back pain that led to his hospitalization. The patient denied palpitations, dyspnea, or fatigue during the hospitalization, but he did report nausea and mild cough without phlegm. The past medical history was relevant for immunocompromised state. There was no surgical history, and the medications were not being taken for heart for the past year. Allergies to Benadryl, there was no family or social history that was contributory to the event. During admission, vitals were stable except for a fever of 38.5, and the patient was alert but in moderate distress. Fundoscopic exam revealed no rod spots, which are part of also of Duke's minor criteria. Cardiovascular exam was unremarkable with no murmurs, which can also be seen with infective endocarditis. Dermatologic exam revealed multiple Janeway lesions, as appear in the picture of the top, multiple in the hands and soles of the patient. Splinter hemorrhages were also seen in the nails. There were no ossular nodes. The genitourinary exam revealed CVA bilateral tenderness, but the neurological exam was non-significant. The TTE, the transthoracic echocardiogram, illustrated the posterior mitral valve leaflet vegetation that measured 1.4 centimeters. This confirming the acute bacterial endocarditis of the patient. During admission, blood cultures and neurocultures were drawn, detecting MRSA. Spine MRI was performed that demonstrated no vertebral osteomyelitis concerning during the time of admission for the patient. Ultrasound revealed bilateral hydronephrosis and splenomegaly, as well as splenic hypoechoic lesions that suggested infarction. The patient refused surgical removal of the vegetation and refused CEE. The patient was only given antibiotic therapy for 6 weeks, after the first 9 days, the bacteremia resolved. This case is illustrative of the value of Janeway lesions in facilitating and expediting the diagnosis of infective endocarditis, allowing for earlier treatment. Early identification of this silent clinical sign can lead to efficient steps to order echocardiograms and imaging, leading to reduced morbidity and mortality. Although the pathogenesis of Janeway lesions continues to be contentious despite investigation for over 100 years, they appear to be vascular phenomena secondary to septic microemboli. Janeway lesions manifest in only 5 to 50% of patients with infective endocarditis nowadays due to the advent of antibiotics. This clinical case substantiates the idea that Janeway lesions manifest more with viral pathogens such as Staphylococcus aureus and with involvement of the left valve and left circulation, as the mitral valve leaflet vegetation was present. Thank you.